Hello, good afternoon. My name is Pedro Povo, and I have the honor to moderate this session on this last webinar. Let's share my screen. This is the last webinar of this program, the fungal sepsis training program that has been held and produced by the European Society of Intensive Care Medicine. This program was possible because of unrestricted educational grant by Gilead, and the target population are the EasyCare members, young residents, fellows, and also specialists, but also those that wish to improve the knowledge in these fields, because this is let's say a higher educational level 2-3 in this area of knowledge. And so the methodology for this program, we developed 6 different modules with 5 with visual lectures, with self-assessment quiz, and also live webinars. This one is the last live webinar. And one of the models is a virtual reality experience model that is already available for you to do the last one. The contributors of this program, we had the excellent contribution of our current president, Elia Azolay, that helped us a lot to put this program working and to make the program. And I had the privilege to co-moderate this program with Marlies Osterman from the ICU of Guy's and St. Thomas Hospital in London, that today is not able to be here. And I am an intensivist and internist from Lisbon in Portugal. And for this, we add the contribution, the expertise, the time and work of 27 experts from different countries in the world that contributed to make these 6 modules, the 5 video lectures, and the last one, the VR recording immersion. Concerning registration, this has been also a very successful program. By June 7th, we have more than 800 registrations and more than 600 participants completed the application from 97 countries all over the world, not only in Europe. And mainly people from intensive care medicine specialty, but others from anesthesia, from ID physicians, and also internal medicine. So these were the 5 live webinars. The first one on understanding the basics, the second on antifungals from the drug to therapy, the third on the invasive aspergillosis in different patient populations, the fourth challenges in some fungal infections, namely the diagnostic specific patients and therapy of mucor. And this last one that we are going to help today is on fungal sepsis and septic shock, an integrated approach. And for this, we have with us, as I said before, Ricardo Ferrer and Ignacio Martin Loeches. So the first live webinar had 78 participants from 32 countries. And the second one also with a good participation from people from different 24 countries. The third on aspergillosis a little bit less, and the fourth from 15 countries. And today, so we will address the issue of fungal sepsis and septic shock. And the take-home messages of these 4 video lectures are in a short message this one. So how do invasive fungal infections lead to sepsis? And so it is important to know that up to 20% of the infected patients may have an invasive candidiasis with a mortality that can be as high as 50%. That the clinical scores, the available clinical scores are not that good to identify these patients. They have a lot of false positives, so they can lead to over-treating patients. And some multi-parameter assessment can help you in identifying that those patients that could have an invasive candidiasis. There is a continuum between colonization and infection, but the line between one and the other is not easy to define. There's a balance between excessive therapy and the risk-based strategies versus delayed therapy, and we are not yet in the stage of identifying well those patients. So there are room for improvement, but some of the strategies, namely the biomarkers, can be used to stop therapy, not that good to start therapy, and is important in the checklist of those patients with candidemia is to check for infective endocarditis and to be aggressive in treatment in this case. And the long-term follow-up in maintenance of therapy is also an important topic, and also to switch from IV to oral. The other topic was antifungal strategies to improve outcomes in septic shock due to candidemia. And this is important in terms of the time to therapy, the issue of fungicidal and fungistatic drugs, and also the effectiveness or not indication to do combination therapy. And this topic has been addressed by Ignacio. And Ricard has addressed the issue of recent advances in fungal infections, insights from the 2021 Surviving Sepsis campaign guidelines. So how the guidelines could improve the process of care and mortality, and some specific recommendations concerning or regarding fungal sepsis are not that strong in terms of the level of evidence, so that there's a gap of research. It is important to have early and appropriate antifungals, and also when needed source control, and that echinocandins are still the first choice. And last, there's a session by Jan de Waal on source control and outcomes of invasive fungal infections. It has been addressed the principles of source control across different types of infections, not only on fungal infections. That should be as soon and as complete as possible. So this should always be tailored to the patient, so to assess the risks and benefits of the source control. The importance of catheter management, because removing catheters is equal to source control, and they should be removed unless not possible, and in some patients is frequent, not being possible to have a new access, a new line. And the impact of these procedures on outcomes remains a topic of debate, and also sometimes the timing. The source control is highly relevant in intra-abdominal infection, candidiasis, and it is also a prerequisite for the efficacy of antifungals, in that fungal infections can disseminate them to different organ systems if they are not adequately controlled. And apart from systemic therapy, source control is very important, not only in fungal infections, but in many other infections. And he also addressed the issue of molds, of mucor infection, and so the importance of surgery and source control in skin and soft tissue of these rare infections. And with that, I will stop here, and then we will start discussing a clinical case with our two experts for today, Ricard Ferrer and Ignacio. And I will ask you to feel free to ask questions to them about the lectures, if you have any question to them about the lectures you have in this last module, and also about the clinical case. We'll try to make the more interactive we can to clarify issues, to discuss the management of fungal infections. So please, use the chat, and maybe some of the experts will also ask you questions, or what will you think is the best approach to a patient, and please use the chat, and I will be with attention to the chat to see what are you asking. Thank you. So now I'll leave the floor to you. Ricard Ferrer, that I'm going to introduce him, is an intensivist from Barcelona, Spain. And he has been already the chair of disease infection, and now is currently the treasurer of the society. And Ignacio Martin Loeches, also intensivist from Ireland, Dublin, Ireland, that is the future, that has been several positions in the society, and that is the chair-elect of the research committee. So please, Ricard, the floor is yours, and Ignacio also.
Hello, Pedro. Thank you for your introduction. And I'm going to discuss with you a clinical case that I'm sure that is going to be useful for raise several questions and also to clarify several of the points we have discussed in the previous session. So this patient is a 28-year-old woman. The patient came to the hospital because upper abdominal pain and shortness of breath. And it's important to know that the patient have morbid obesity, and she had operation 5 days before. It was a laparoscopic sleeve gastrectomy. So this is the exploration at emergency department arrival. The patient was without fever, blood pressure is normal, patient was tachycardic, 130 beats per minute. Respiratory rate was 26 with lung sounds dysmenorrhea in both lungs, bases, and also some edema, oliguria, and importantly, peritonism. On the chemistry, the patient had leukocytosis, high levels of CRP, PCT was 0.5, and the rest is normal or not additional data. And this is the chest X-ray. So we have this occupation in the left pleura. So I don't know, Pedro, if you want to ask to the audience about potential diagnosis or any thoughts from the audience about this patient?
What would you do? What do you think? What could be wrong? Any thoughts? Any ideas? Any questions that you would ask or exams that you would ask to help you in the management of these patients? Ignacio, what do you think? Just to start the discussion.
Well, I think that when we have a patient like this, obviously we need to take into account risk factors. I think that it is really important to know if the patient has some degree of immunosuppression, if a patient has, in terms of the antibiotic treatment that you are going to provide. So in this case, what we have is we have a patient with a consolidation in the chest that could be quite common in this type of patients. Don't forget that these patients do develop atelectasis because of the pain, and sometimes they can develop also parapneumonic effusions related to the surgery. But at the same time, we need to consider that the most common infection is going to be a respiratory infection, but we cannot exclude that two processes can happen at the same time. So in this case, we can see these chest X-ray, but at the same time is what I mentioned about the possibility of having another infection that could be related to a leak.
There's a possibility in the chat from Farah Ra. Could be a HAP with a parapneumonic effusion. So a little bit in accordance to what you are being said. Sorry to interrupt you.
No, absolutely no problem. So I think that this is, so I have to say that I agree with her that she mentioned this. And another thing is that when we are talking about, probably we can talk about peritonitis later, but I think that for the moment we should focus on the respiratory infection. And probably I think that there are two factors that we need to consider when we are providing antibiotic treatment. So one would be the degree of severity, and the other is the local ecology. It's not the same if this patient is in Barcelona or is in Athens or is in Oslo. So I think that these are important features when we are going to treat this type of patients. And more important than the country, I could say the epidemiology of the unit, because one of the things that we have done is in the last few years, we talk a lot about ecology. But I think that even in the same country, we can have different ecological features. And I think that this is something that, I discussed with both of you, with Pedro and Ricard, that sometimes you have a hospital that because of the type of patients, you are going to have more CRE, you are going to have more Pseudomonas, or in others you are going to have MRSA, or you are lucky and you don't have many MDRs. So I think that this is an important factor when we are going to treat this type of patients.
I think that, can I ask the audience and also you, would you, at this stage, would you be comfortable just with the chest X-ray and the lab parameters that has been shown just to start therapy, or would you ask for additional exams? Are you comfortable with the diagnosis of being HAP? Just what do you think?
Well, I think that based on the problems that she has presented, I think that you cannot be confident. As I mentioned before, I think that you have to also consider that the patient might have a complication induced by the surgery. And obviously what I would do is probably I would perform a CT scan, including a CT tap, in order to assess the chest and the belly, and to be sure that we are not having a problem. So based on the different features that we have here, the patient is sick. Probably what we need is another important matter when we are talking about antibiotic treatment is we need to also to consider two important points. One is resuscitation. I think that is really important to start to resuscitate this patient. That means with fluids, with hemodynamic management in order to optimize perfusion. And the second, and you mentioned during your slides, Pedro, I think that source control is an important feature. Sometimes we can start antibiotics that I think that the majority of us, we would be happy, but obviously we need to be sure that we are not missing a source.
So the suggestion also from Farara is to start piperacillin tazobactam and to perform a CT tap, as you just mentioned. So do you agree with this antibiotic? Do you, even before any other additional exam?
Well, in my opinion, I think that the answer could be yes. I think that if we are looking at the different guidelines that they are for intra-abdominal infections, I think that they are different. But I think that if you are looking at, for instance, the American guidelines, they are recommending the use of either ceftriaxone plus metronidazole, piperacillin tazobactam, carbapenems, or even fluoroquinolones in that regard. The other important thing is that when we are looking about secondary peritonitis, I think that it's really important to consider where is the area that you have in this case, the potential leak. I'm telling this because if you are looking at the stomach, I think that one important feature is that you need to take into account streptococci and probably lactobacillus, and also Candida infection. So we know that Candida is a colonizer in the upper GI tract. This is something that we can see in gastric surgery and in esophagectomies. So this is an important feature. So if we are looking at the biliary tract, I think that, for instance, the majority of this is sterile, but I think that E. coli, Klebsiella, and some enterococci can be found in some patients. When we are looking at the proximal small bowel, I think that, again, you need to consider some particular organisms. You are going to have still some gram-negatives, such as E. coli or Klebsiella, and lactobacillus, as I said before, that is very close to the gastric content. But then you are going to have some enterococci, but less gram-negatives, that they are going to be more present in the large bowel. So we know that in the colon, we are going to have a majority of bacteroides, more anaerobics, such as Clostridium, again, Enterobacter, E. coli, Klebsiella, and finally, in the distal ileum, so when we are having, like, for instance, a very distal leak, you are going to also to consider that these anaerobes could be even Bacteroides fragilis or Peptostreptococcus, some Enterobacters. So I think that this is important because when you are going to provide a treatment, in this particular patient, I would consider that the use of piperacillin tazobactam could be a reasonable alternative. You can even go with ceftriaxone and metronidazole because it's very unlikely that you are going to have a pseudomonas in that area. Even ertapenem is another good option for this type of patients. And I think that you need to use an antifungal. I'm not going to go very fast because probably when we are talking about antifungals, I'm sure that you would like to talk about the epidemiology again and probably different spectrum of that. So that could be my option. So probably these antibacterials, ceftriaxone and metronidazole, ertapenem, piperacillin tazobactam, and an antifungal that I'm not going to say which one yet, but this is...
just a short comment. And what about if the patient is or not on IBPs? Does it change your approach because of the stomach having acid or not?
Well, I'm not particularly. So you mean PPIs?
PPIs. Sorry. Yeah.
So I think that that is definitely a factor that you are going to have less possibilities, that you are going to have less gram-positive bacteria, and obviously the production of gastric content is going to sterilize the majority of them. But it's not going to preclude that you cannot develop a candida there. So it's well known that PPIs is a good risk factor for developing more candida infections. And they are really good colonizers, especially in patients that they have Solingera lesion and they are treated with PPIs for a long term.
Okay, so can we move on?
Yes, to continue a little bit the discussion, it's about... So we have a patient with abdominal symptoms and on this X-ray. So we are still struggling if this is coming from the lung or is coming from the abdomen. But the patient have not organ failure at that moment. So should we run with the antibiotic or we need to investigate a little bit more before applying empirical antibiotic? This is an eternal discussion. If it's antibiotic should be given just as a shot, or we need to wait a little bit more. For sure, the patient have an infection, so we are going to administer antibiotic, sure. But the question is, we need to investigate a little bit more about the source, or we can go for pip/tazo as suggested, because the coverage for the lung and the abdomen will be good, both cases. So it's more a theoretical discussion, but I think it's also important.
Yeah, sure. And anyone from the attendees or delegates that would suggest or ask for any other option, or just start antibiotics and do a CT tap has been already discussed? Or Ignacio, what do you think?
Well, I like it very much what Ricard has said, and I think that this is an important matter when we are treating at the patient. So I think that obviously no one would criticize antibiotic stewardship programs, but I think that in the last years, my feeling, and I cannot say that this is just a reality everywhere, but my feeling is that we are in the holding antibiotics because we need to, be careful with antibiotics. I am a firm believer of that, but I think that at the same time, we have to be very aggressive when we have an infection to give antibiotics. The important thing that I think that Ricard challenged us is that he said, well, the patient is not with very much organ failure. And I think that this is, again, a very important matter. So the thing is that if the patient is not having an organ failure, to hold antibiotics or not, I think that in this case, I think that is very good enough to be sure that probably if you are not treating the infection, that is quite clear, you are going to develop organ failure. And I think that this comes again to the discussion of, probably definitions in the sepsis. Like, for instance, in the sepsis definitions, now the sepsis definition is towards organ failure. So, but I think that, and many of the scores, like the quick SOFA, for instance, they are not defining sepsis as it is. They are defining organ failure. So saying all of these, I think that what is important is we need, in my opinion, to treat the patient when the patient has an infection very clear. Another story is that you have a patient that is many days in ICU, that you have reasonably explorated, that you have no sources. Like, for instance, you have done a CT scan, you have done a chest X-ray, and there is no consolidation, no purulent secretions, and the patient is having fever. So yes, there is where we have to be careful that maybe having fever and having white cells does not preclude, if the patient is stable, to continue with some more investigations. But I think that in this case, where you have a patient that is very, very likely, based on what Ricard has provided in terms of information, that the infection is there, I think that we need to treat them immediately without delaying the look for the source control. So we need to see that there is something in the abdomen that is going to also explain this clinical deterioration.
What do you think, Ricard? Do you agree?
Yeah, fully agree. So if we are very convinced that the patient have an infection, for sure, if we wait, probably the patient will deteriorate more. And probably our empirical therapy in this moment should cover both sources. So we have to be broad, but I think we should be fast.
Okay.
Okay, so this is the CT scan of this patient. So as you can see here, there is an esophageal leak, also with a mediasthenic abscess. There is also pneumomediastinum, probably pneumopericardium also, and some hydropneumothorax and some consolidation in the lung. So as we are discussing, the patient was treated with piptazo. At that moment, not blood pressure were taken, not fluid resuscitation was needed, not central line, and the patient went straight to the operating room. So basically, surgeons did a bilateral subcostal laparotomy. There is a peritonitis there, and also there is a dehiscence of the staple line suture with an esophageal and gastric leak and an empyema. So the patient was operated, several drainage were placed, and during the surgery, the patient need fluids, 2.5 liters, norepinephrine during 30 minutes. Urine output was acceptable, and lactate was below 2, and SCVO2 was 79. So quite stable, and the chest X-ray after the surgery with the drainage in place shows some improvement, especially on the empyema, but there's still some consolidation there.
So at this stage, what do you think we should keep the same strategy concerning antimicrobials. We should change. We should wait for the cultures. What would be your approach here?
So I think that we are completing the bundle in terms that the patient have broad spectrum antibiotics, have source control, and have an adequate resuscitation during the surgery. We need to be sure that the surgeon have sent the samples to the lab to get that together with the blood cultures to reassess the case. And probably as Ignacio was discussing, if the leak is in the esophagus or in the stomach, we have to think in Candida. So,
and what would be the risk of having Candida? Is 10%? Is 15%? Is just to discuss with the attendees, what would be the risk of having a Candida infection at this stage?
So the question is, which is the risk you want to accept? So the risk is going to be more than 10%, in my opinion. So for me, this is enough to consider antifungals. Because
and do you think first biomarkers like beta-glucan could be helpful here, just to
of course
to guide you, or they also can lead to over-treating patients or not being present? So what would be here additional strategies that can help you in starting, or strategies then later on we can also discuss the stopping. But in here, what would be additional strategies that can be useful guiding you here?
Yes, you raise a very good point, because cultures are going to take some time. So biomarkers can help in the sense that, mainly in the sense of the negative predicted value. So if beta-glucan, the levels of beta-glucan are low, probably the risk is very low. So this is I think this is the most interesting value of beta-glucan, that the negative predicted value is high. So you can discard fungal infection if the levels are low. So that can complement your strategy and helping in your decisions.
Okay. And Ignacio, do you think, do you have a different opinion? Are you happy with the strategy? What would be your approach? Because this is a gray zone. I think we are in a gray zone. There are no clear recommendations.
Well, I would like to maybe suggest to the attendees to have a quick look to the guidelines that, well, more than guidelines, where it was a task force, because there were some areas that we had not too much evidence, as you said, Pedro, is a gray area. And what we did was we published some guidelines that they were trying to help the clinician at the bedside how to manage patients with invasive candidiasis and candidemia, that they were not immunosuppressed. And one of the things that we recommended is, I think that it's important to distinguish if you are abdominal surgery or not abdominal surgery. I think that there is an overuse of antifungal treatment in patients that they are not with abdominal surgery. And this is something that we can see very, very often, that many patients with non-abdominal surgery, they are receiving broad-spectrum antibiotics and they are receiving antifungals. I think that there is a good evidence. For instance, I remember one paper from Elia Souley and Jean-François Timsit that is called Empiricus. Is a paper that was published in JAMA a few years ago. I think that was around 2017, if I'm not wrong, or 2018. Apologies if it's not the right time, but around that time. So that they did a very pragmatical approach. Patients that they had organ failure, that they were on broad-spectrum antibiotics, they were given similar to the strategy that we do sometimes in medical patients, that we don't know what's going on. The patient is with fever and we give antifungals, and there was no difference whatsoever in mortality. We can discuss if mortality is the right approach, if the mortality is a good outcome or not. But I think that this is a very...
But, Ignacio, but with less invasive fungal infections, that was, they decreased the rate, but without impact on mortality. That's
correct. Less invasive fungal infections because obviously the patient was receiving an antifungal. So obviously it was clear. And coming back to the guidelines, I think that in this case, we have abdominal infection. And I think that we could start using what we call, Candida scores or this type of scores that there are several. There are, different type of scores that, in my opinion, are quite interesting because they are going to provide a good understanding of what is going on with the colonization. So I think that probably the best known score is the Candida score that was published by Cristobal León and collaborators in Spain first time. And with that, we had the PAPI-2 score, the colonization index, or even the Ostrowski index. And as Ricard said, these are scores that they provide a good negative predictive value. So they are like the D-dimer. So if your if your Candida score is low, you are very unlikely to have a Candida infection. Now, I think that we are into an area that is an area that more uncertainty, that is the use of biomarkers. What we recommended in the guidelines is not to use biomarkers when we are not going to start antifungal treatment because they are going to, it has been reported with different studies, one from Anaïta Rousset, from the German consortia and also in Italy with the group of Massimo Antonelli. I think that showing that the use of these scores without treatment, they overuse antifungals. So I think that probably what we need to do is to treat the patient when we consider, based on the risk factors and based on the site of the leak, these fungal infections, and then to send the beta-D-glucan. Beta-D-glucan, despite of our hopes, is a poor biomarker in terms of detection, but could provide, in my opinion, a very good negative predictive value, but only when we have started the treatment. So, and this is what we do in our unit. So we treat the patient. In a patient like this, I could have started treatment. I could have sent cultures from the operational room. Sometimes we need to insist to the surgeons, please, when you are in the theater, to get samples. At the same time, we need to talk to the microbiologist because by definition, an abdominal infection is going to be polymicrobial. So they are going to collect the cultures that they want because they are going to pick samples. And I think that is important to know this, and probably to get the beta-glucan and to see if the results are. We did use in these guidelines the level of 80 for beta-glucan. We consider that level was, very sufficient in order to provide, picograms per millimole in case that we have abdominal sepsis. I think that for the abdominal sepsis, we did use 80 as a threshold or cutoff. That is true that probably in medical patients, the DBG level might be a little bit more elevated, probably around 250. And we also have to consider other mannans, including the galactomannan that is going to be providing some other information, and also not to forget other biomarkers like the well-known CADGA, that is an immunofluorescent assay that is indirect and could provide also some diagnosis.
So, Pedro, maybe also what about PCR? Because PCR can be very useful, but also can overestimate the colonization. So I think also PCR is more and more available. And it's also something that we can consider not only the biomarkers. So I will add that to the strategy probably, also in that case. So I think Ignacio explained very well the two syndromes we are discussing today. So the first one is this syndrome. So it's a patient with probably perforation in the esophagus or in the stomach. And we are considering is Candida is part of the potential infection together with other microorganisms. And the other syndrome, which is patients which are septic in the ICU, and they have risk factors for candidemia. And for those patients, we want to be preemptive, especially if they have these risk factors. And risk factors are grouped in risk factors related to Candida colonization or loss of integrity of the mucosa, and then immunity. So if the patient have risk factors related with these three groups, and together with some time in the ICU, especially after 2 weeks, are those patients with risk factors. These risk factors can be put together, as Ignacio said, in a score, Candida score, and together with biomarkers, we can try to be preemptive. But it's a completely different syndrome, I think, from the situation we are discussing. So we have the two syndromes where Candida can be involved, this peritonitis, mediastinitis, and then sepsis in a patient with risk factors in the ICU, which is in patients which are immunocompetent, in fact, but after several days or weeks in the ICU, because they have pancreatitis, surgery, parenteral nutrition, etc., they are adding risk factors until the patient presented candidemia and sepsis. Yeah. You're mute, Pedro.
Sorry, I fully agree with you. I think can we just move on? So with this case.
So after the surgery, the patient was still hypotensive, but still responding to fluids, needing everyday crystalloids and colloids. Urine output was a little bit low, lactates increased. Patient was in mechanical ventilation, cannot be weaned from the ventilators. Biomarkers, CRP at least are going down and still some fever there. 2 days after the surgery, still some fever. Biomarkers still high, still needing fluids, colloids and crystalloids. There is some increase in urine output, some improvement in lactate. So this patient was not doing well, but also not doing bad. The culture was cultures coming from the surgery show Streptococcus intermedius, Fusobacterium mortiferum, and Candida glabrata. So fluconazole was added to the treatment to this patient together with piptathone. This was day 2 after the surgery.
No blood cultures yet. No blood cultures.
No blood cultures. No.
Okay. So now we have polymicrobial infection with bacteria and fungi. So what would be the strategy, the best strategy to this patient? So the option was fluconazole. Do you all agree with the strategy? What do you think?
There is some comment on the chat.
Yes, is fluconazole a good choice for Candida glabrata? So Ashrad, what do you think? Would it be your choice to put fluconazole in Candida glabrata?
Are you asking me, Pedro?
No, I'm trying. Ashraf with the. So before meanwhile, what are the options, and then what would be the best? So the answer from him was he prefers echinocandins. Okay, so what we think at this stage, with this isolation, what would be your choices? Ricard.
No, I think, Pedro, that this is very depending, and we discussed this at the beginning of this session, which is the epidemiology of your country, or for your city, or for your hospital, depending to the resistance of Candida glabrata for fluconazole. So if you have mainly sensitive Candida glabrata, you can go for fluconazole. But if you have some risk of resistance in that situation, in the patient that is still septic, I think guidelines are supporting the use of echinocandins. And not only because the resistance, also because echinocandins are fungicidal and azoles are fungistatic. So for both reasons, I think maybe echinocandins are best option. But again, it's depending on your ecology.
Ignacio, do you agree? Or do you?
Yeah, I think that, I agree that ecology mandates, and definitely one of the problems that we have with glabrata is that in general, glabrata exhibits intrinsically low susceptibility to azoles, especially fluconazole, and will rapidly acquire antifungal resistance in response to azoles and even echinocandins. So we cannot forget that it depends on the type of country that you are practicing, but the problem that you have with many non-albicans species is that we have seen that the sensitivity to azoles is rapidly decreasing. So I think that probably at this time, it's probably not very wise to use a fluconazole as a first line dose, because I think that you are likely to develop a problem. So the other thing is that echinocandins, as Ricard has said, is going to have a fungicidal activity against the most Candida species. Don't forget that for Aspergillus is a different story, because it's going to be fungi static in Aspergillus. But well, I think that because of the type of action in the cell wall is important. The other thing is that is it, and this is, based on the guidelines, first line option would be echinocandins. But obviously, in abdominal candida, there are many, many questions still there. And it's about the use of echinocandins, or, for instance, the use of amphotericin B. Amphotericin B has a bad reputation because amphotericin B is considered that is very nephrotoxic. But I think that it is important, as we did in the guidelines, and we receive a letter suggesting that amphotericin B could be an option, that it depends is a lipid formulation or is not a lipid formulation. The majority of the countries, they don't have the oxycolate anymore. So I think that the oxycolate was very toxic, but the lipid formulations are less toxic, and they are going to have a good profile. Another important matter in this case, I think that for a glabrata, I don't think that this is a right approach to use fluconazole. Don't forget also that even in parapsilosis and in glabrata and some other, including dublinensis, there are a good number of breakthrough infections with fluconazole. So we are going to have these type of infections that they are really common in Candida. So for that reason, you have to be aware. In case that you have the fungigram of the Candida and is sensitive to fluconazole, imagine that we have an albicans, it's not a breakthrough infection and is sensitive. I think that it's important to go to a high dose. Remember that underdosing with fluconazole is very, very common. And this is one of the main problems that we have.
That was the question. What would be a high dose, please?
High dose, in my opinion, would be over 1,200 milligrams for daily dose. I think that this is probably the dose that we should recommend. I think that definitely 400 every 24 hours should be discouraged, as it is written in some guidelines. 400 by BD, probably you are almost there, but I think that to be sure that you are, especially in a patient with septic shock, high volume of distribution, I think that you need to go to 1200.
And do you recommend to give the first dose of 800 milligrams?
Yeah, I think so. But I think that, again, I would recommend that probably based on the guidelines, I think that in the chat, we have put this task force document. We recommended echinocandins as a first option. Another important factor is even that you have a sensitive candida, if the patient is with renal replacement therapy, fluconazole is a drug that likes to pass through the filter. So you are going to have a very high underdosing. So in patients that they are even with sensitive candida, so be careful if the patient is on high flow renal replacement therapy. In that type of patients also would be ideal. I know that is not everywhere available to have therapeutic drug monitoring. So, but fluconazole is a drug that in my opinion is like some beta-lactams that they have a high protein binding that they are likely to have underdosing. So you have to be extremely careful.
Okay, thank you. So, Ricard, do you agree with this? Do you have any other options? So that would be, yeah.
No, I fully agree. I fully agree with Ignacio. I think that fluconazole was a little bit risky, let's say. So my best option will be for sure echinocandin. Fluconazole have these limitations and also the limitations that pharmacokinetic limitations that also Ignacio alluded to. So really, fluconazole was not the best option for that lady.
Okay, so we have 5 minutes to end. So can we? Yes.
On day 3, the patient was on parenteral nutrition, not an important change. The biomarkers, in fact, were doing well. However, on day 4, we have worsening in the X-ray. So we went for a new CT scan, and the patient, because of progression of the, let's say, emphysema, the patient was transferred again to the operating room. So the local evolution of the infection is not improving. The patient needs additional drainage to achieve lung re-expansion and drainage of the source of the infection. Biomarkers went up again, and then on day 10 after the surgery, the patient developed clearly septic shock with high fever, needing vasopressors and hydrocortisone, ARDS, increase in FiO2 to 100% prone position, and also AKI needing hemofiltration that we learned that for keeping adequate levels of azoles, it's really a challenge. So in that situation, we decide to complete source control with an esophageal endoprothesis, and there is not additional need of source control, just the placement of endoprothesis. In that moment, the mediastinum, the pleura was doing well. It's only the bilateral infiltrate, and no additional cultures. Everything was negative, but Candida clavata was colonizing the lung also. And in fact, that Candida clavata was resistant to fluconazole. So the patient was switched to anidulafungin, and the patient received treatment with anidulafungin for several days.
There's a question concerning beta-D-glucan. So here, that's, I think it's important. Here we have a patient with an invasive fungal infection. We didn't know if there is also positive or negative blood cultures because blood culture has not been collected. But the issue is, if we have beta-D-glucans in this patient, can we use it to monitor the therapy, to if the therapy is making any difference, if the patient is responding or not?
So I think if we want to consider beta-glucan, as Ignacio said before, and he was suggesting, and in fact was written in the paper they published, that levels below 80 picograms per ml can suggest early stop. I think in this situation, in a patient with multi-organ failure, I think it's not the case. So I will not monitor until the patient really improves, not during organ failure.
And what do you think, Ignacio? Can we use beta-glucan to see if the infection is improving?
Yeah, I think so. I think that in patients that they have problems with source control, probably is a good way to monitor. Also, I think that the use of biomarkers, I remember one paper that we published with Andrea Cortigiani, that we did use the role of DTaVG plus PCT, that I think that PCT, even that it is said that is a biomarker that might help or not, I think that this is the need of putting all together. I think that there is not only one biomarker, there is not only one aspect. I think that we need to integrate. I think that Pedro, you have given many lectures about this, and many of us have learned with you about this, that the role of biomarkers, whichever it is, that they are fungal biomarkers or host biomarkers, they need to be taken into account. I think that to add beta-glucan to the management is something that is going to be really important. Probably in this type of patients, we are going to have a sterilization of the site, because obviously we are not going to get there. And I think that an important matter, especially in esophageal injuries, esophageal and gastric injuries, is that recurrence is quite common. And for that reason, I think that we need to have a very good contact with the surgeons. And in that regard, sometimes the use of OGDs is going to provide a very good visualization of the issue. In this case, might be not needed because there was an stent there, but sometimes is a good point to have this. I just remember, for instance, a patient that I had over the weekend, that we had a very high suspicion of a leak, and until we did the OGD, we didn't really diagnose well. So I think that in this case is important. The question about BTDG every 48 hours,
yeah,
I don't think that is really needed. I think that definitely what we can do is to maybe to do DTaVG not in a 48 hours. I think that it depends on the patient, that probably when you are prolonging the treatment every 4 or 5 days could be reasonable, but this is not supported by any guidelines. This is just a clinical experience.
And what about the use, looking at the fungal in the feces, that was another question. Does it make sense or not to monitor infection, to monitor the presence of fungal in the feces?
I don't think that it makes much sense to do this type of tests. We know that in Candida could be a colonizer in the feces, and in stool is really something that it could happen. It's very unlikely that the presence of Candida in stool is going to change, management. The majority of these patients, as they receive broad-spectrum antibiotics and broad-spectrum, in this case, antifungals, they are not going to have any growth. So I personally don't think that is something that we do routinely, and not routinely. I don't think that is really needed for management.
I would just to add one comment concerning beta-glucan. Sorry, because of the monitoring. It can the kinetics is very slow, so it doesn't make too much sense to monitor the decrease, because it can remain very high, not related to the infection itself. Correct. And another important question is, what about the stent? Could the stent be related to an increased duration of therapy because of being colonized by the candida? Because everything that you put that is let's say a plastic or whatever is easily colonized. What do you think about the stent, Ricardo?
Well, no, I think the stent should be removed when possible. So I don't see I agree with you that can be something that can prolong the therapy and prolong the infection. So in that case, we keep the stent for I think 3 weeks. But after 3 weeks, we remove the stent when we are convinced that the leak was really well controlled. So, yeah. And
did you have in this case the result of the sensitivity to the other antifungals, or only to azoles?
No, we have the sensitivity for echinocandins also. Was sensitive.
Okay. Are you aware of your settings of problems with resistance of glabrata to echinocandins or not? Because that's something that has been at least described in some settings. I don't know if it happened in your setting or not.
Not for glabrata. Very, very uncommon.
Okay. And Ignacio?
Yeah, I think that the difference with glabrata here, our main issue in Ireland and also it happens in the UK is more parapsilosis rather than glabrata. The problem with glabrata to me is not the intrinsic resistance, that it can happen, but is that breakthrough infections. I think that you might have a candidate that is going to show you sensitivities adequate to fluco, but then is a breakthrough infection. So I think that in glabrata in particular, I would be very careful with the use of fluconazole and to have a very close contact.
And the resistance to echinocandins? No report.
We don't have here, I have to say. Probably I could say that the very little cases of echinocandin resistance is because we had a non-well drain source that it creates a high burden of disease, and then the use of echinocandin made that some strains became resistant, and this is the reason that they are only sensitive to ampho-B. But I have to say that the majority of these cases, they were related to a poor source control, sometimes not because the surgeon is not good. It's because, as this case was nicely presented by Ricard, there are areas that they cannot be well drained, and the mediastinum is a good example.
Okay. Ricard, any additional comment, or can we move?
No, the patient did well, as you can imagine, and after the adequate source control and antifungal therapy. So the patient, of course, needs a very prolonged hospital stay, but you can see in the images that the resolution was good, and also the evolution of the biomarkers was very good. So it was a successful.
A question is, for how long do you keep echinocandins? So here was 22 days. Why 22 days and not 15 days or 21 or more? I don't know. Just why 22 days?
Yes. So the patient is coming from some period of inadequate therapy. So with some old days, it was 22, but probably days of adequate therapy were 2 weeks. So
okay.
But as you said, as we don't have blood cultures, it's difficult to guide the duration of this therapy. And as the candida were resistant to fluconazole, there is not only the possibility to de-escalate. So if candida had been sensitive to fluconazole, then maybe we went empirically for echinocandin. There's the possibility of de-escalation, but not in this case. So the patient received echinocandins for 2 weeks.
And she had also additional problem because she was on total concentration for 35 days, so the oral route was not available for
Right.
Ignacio, do you agree with the duration? Do you think it should be longer, shorter? What do you think? Or how do you stop therapy in these patients?
I think that, probably the use of 2 weeks should be enough. With that, I don't see any problems.
But after adequate source control.
Definitely adequate source control. The other thing is that, as I mentioned before, I think that probably the use of beta-glucan could provide an adding information. And as I mentioned, and there is a question in the chat, the use of PCT. I don't think that PCT should be used as a standalone tool. I think that is going to help with giving more information. I think that probably is more relevant in case of candidemia than invasive candidiasis. But I think that probably the more data you have, the more chances you are going to provide a better treatment. These cases are not guideline cases. They are really depending on the clinical progression. And I think that, this is a reality. The more information you get in this type of patients, the better, in my opinion.
And just to answer the question, the DuraPop trial was not with fungal diseases, was with complicated intraabdominal infection. So you cannot give 8 days of therapy in this kind of patient.
I would like to only say something about the DuraPop trial and another type of patients. Other type of studies, not the DuraPop. I think that the DuraPop is a critically ill study, so it's a randomized study. So I think that this is a perspective. But I think that it's important in other studies. Like, for instance, I remember one study that was in the New England Journal of Medicine suggesting the use of 3 to 5 days. Sometimes, we need to really read well, these studies, because all of these patients were not critically ill. The mortality in the overall population was less than 1%, and all of them, they had source control. I think that this is an important matter. Source control mandates everything, in my opinion, and severity.
Fully agree. Ricard, any comment?
Fully agree. No more comments.
Okay. I think maybe we are a little bit over 1 hour, and I know that you have already additional commitments. I want to thank you for this wonderful discussion about this complex clinical case. I just want to ask if the attendees have any additional question. So if so, please write it in the chat. I also want to thank the office, Anita, and also the technical team, just to provide us with this wonderful also live webinar, and to thank both experts, Ricard Ferrer and Ignacio Martin-Lashes, for these wonderful discussions, always very productive, and I learned a lot with you both. And there's no discussion, no questions, so with that, I will just thank you again, and bye-bye. See you soon somewhere. Bye-bye.
Bye-bye.
See you. Bye-bye.